served as a reviewer for the CDC and for multiple medical journals. He authored 3 books and over 60 peer-reviewed clinical genetics and genomics articles. His review interests include genomic testing, gene therapy, protocols, rare neurodevelopmental disorders, and Fragile X syndrome. Dr. Velinov, take it away.
Thank you very much. Do you hear me well?
Yes, loud and clear.
Okay, great. Do you see my slides?
Yes, we do.
Okay, great. Well, thank you very much for the nice introduction and for inviting me to do this presentation. This is about genomic testing, which is becoming more and more popular in prenatally and postnatally. So I'll be covering some of those issues today. I just learned that I have one conflict of interest that I didn't know. That's why it's not reflected in the slides. The Rady Institute for Genomic Medicine is has awarded us a small grant support to conduct a pilot study on newborn screening, which I will mention in my talk a little bit later. No other conflicts. The learning objectives are, after the study, participants should be better able to understand the development of new DNA sequencing approaches, summarize the new guidelines regarding prenatal testing, and learn about studies on prenatal and postnatal genomic testing and the associated improvements of newborn health. Now, when we say genomic testing, we understand 2 tests generally: whole exome sequencing and whole genome sequencing. Most of the data that we have collected so far is on whole exome sequencing, which was clinically available since 2011. The whole genome sequencing is becoming more and more popular for the last several years, but we still don't have that much data, especially for prenatal testing. We have more data on whole genome sequencing postnatally. So a couple of words about the difference between the classic sequencing, referred to as Sanger sequencing, versus the next generation sequencing. The classic sequencing that was developed in the 70s consists in amplifying specific portion of the genome that we want to sequence, usually a short sequence, about 400, 500 base pairs, and then subjecting this template to 4 different synthesis reactions in which the enzyme is elongating DNA sequence corresponding to the template and stops at some specific portions where the nucleotides are inducing stop of the sequencing, and that in 4 tubes is done for the 4 nucleotides, ACTG. And that's how we get a spectrum of bands that stop at particular spot where we have specific nucleotide that we can resolve on electrophoresis and see those patterns that are corresponding to the sequence. And on the left-hand side of this is depicted automated sequencing, which is using not traditional gel electrophoresis, but capillary gel electrophoresis, and every nucleotide is labeled with specific color. And we see one heterozygous nucleotide on the bottom of the left side, A and G, which is shown here with lower peak, but 2 colored peak for 2 different nucleotides. So this is the classic sequencing. On the right-hand side, you see computer generated sequence of next-gen sequencing, which consists in sequencing tens of thousands of fragments in the same time. They are first enriched for the sequence that we want to sequence, or if it is whole genome sequencing, it's the entire sequence without enriching. And because the sequencing happens in a parallel way in so many different fragments of the genome, we can sequence very large number of genes or the entire genome this way. And also every specific locus, every specific point of the genome, of specific gene is sequenced many times. So this is, you could say, statistical sequence of how many of the sequence reads contain A in this specific slide or G. So that's how it is determined whether there is heterozygosity of specific nucleotide in specific place. This type of sequencing is also has one feature that the classic sequencing doesn't have, the depth of sequencing, which varies when we want to enrich the genome for specific sequence that we want to sequence. They are not enriched in an equal way, so the depth of sequencing, the number of reads is different for different genes. So sometimes we have lower than optimal coverage of specific portions, specific genes. This issue doesn't exist in whole genome sequencing because we don't enrich for anything, we just sequence the entire genome. So this is one of the advantages of whole genome sequencing evenly the entire sequence. This is a graph that demonstrates the decrease in the cost of genomic sequencing. It starts with 2001 and it ends in 2019. And the white line that you see on the top is Moore's law, which indicates how the computer technology decreases, that the cost of the computer technology decreases with time. And the green line is about the genomic sequencing cost. So you can see how dramatically it decreased from 100 million to sequence the entire genome in the beginning of this century down to $1,000 per genome, much faster than the computer technology. And you see a steep decline of the cost around 2008, a little bit between 2007 and 2008. And that's when the next-gen sequencing got introduced for wider use. So that is the contribution of next-gen sequencing for decreasing the cost of genomic testing. And that's why the genomic testing becomes more and more popular with recently. This is a study that was done in 2022 by an international group from US and several European groups that looked at the referrals for genome-wide sequencing during pregnancy, prenatally, and it's a meta-analysis which involves several papers and looks at reasons for referrals and the added diagnostic yield of genomic sequencing. And you can see here that there is a very high diagnostic yield for certain reasons for referral for genomics testing. For instance, isolated skeletal findings on prenatal ultrasound is associated with 53% positive findings on genomic testing. Even better, isolated echogenic kidneys correspond to 72%. So they concluded that all these causes for referral for genomic testing are relevant, and they lead to significant findings using genomic sequencing that provides very efficient way to determine genetic diagnosis. And based on that analysis, they have issued certain guidelines. So these guidelines are not US guidelines, they are international guidelines that were established by US groups and European groups. So there are two main indications for referral for genomic testing prenatally. One of them is abnormal fetal ultrasound, and this for this recommendation, they are saying that the microarray should be reported normal before we go to genomic testing, and there are two kind of specific indication. No genetic diagnosis was found after microarray, and the genetic experts consider the phenotype highly suggestive of genetic etiology. And sometimes you can go straight to genomic testing if the pattern is strongly suggestive of single gene disorder, but you have to keep in mind that prenatal exome sequencing is not validated for CMV, so microarray should be done in parallel or before or after the exome, whole exome sequencing. I can say that this is changing gradually. The genomic sequencing becomes more and more instrumental in picking up clinically relevant CMVs. So it may soon replace completely the microarray. The second main indication for referrals that this panel recommends is family history. If you have a couple that had an affected child with major multiple congenital anomalies or major anomaly with unknown diagnosis, and we have time constraint during the pregnancy, we can consider genomic testing for this pregnancy. Or they are saying if parents present for preconception counseling and there is a child that was born with congenital anomalies and there is no diagnosis, you can do sequencing, exome sequencing for biological parents. Now, the second indication is not widely used currently in US, just suggested by this international team. US guidelines. The US guidelines, ACMG issued in 2020 guidelines that suggest that exome sequencing may be considered for a fetus with ultrasound anomalies and normal microarray. And they're saying that there are no other indications for whole exome sequencing prenatally. At that time, the American College of Obstetrics and Gynecology is even more conservative. The guidelines in 23 are stating that genome and exome are not recommended prenatally. Now, this is not, most of the experts in the field do not accept this recommendation, and it's changing gradually with time. So I'm hopeful that they will issue kind of not as conservative guidelines soon. This is a study that was done in Canada by a group in Alberta, Canada, that studied. Alberta has 50,000 births a year, and the population 4 million. For comparison, New Jersey has 100,000 births, a double of this. And they have studied about half of the pregnancy, all the pregnancy, and selected out the pregnancies that were referred for prenatal evaluation in one of the centers, which was about half of the pregnancies in Alberta. And they identified 250 patients that were referred for prenatal molecular prenatal testing, with 73 patients diagnosed with specific genetic disorder, or 30% of the referred patients. And they have compared here the diagnostic yield of different methodology, microarray, over 40%, panel testing, over 50%, exome sequencing about 15%. Now, this graph is a little bit misleading because the exome sequencing will diagnose all the disorders that are included in the panel test. So if you do just exome sequencing, you will, without a panel, you can diagnose over 50% of the babies. And even more than that, currently the reading of the exome sequencing is becoming better in detecting microdeletion and microduplications, which can even replace the microarray eventually. So the exome sequencing may become universal testing or genome sequencing, which is progressively involved in clinical testing. So on the left-hand side, they show the proportion of patients that were referred for prenatal testing, and the largest group for referrals were abnormal ultrasound, and the second largest was positive family history, and some other reasons for referral that are not as common, like positive first trimester screening, abnormal rapid aneuploidy detection, recurrent loss, and others. So this group continue further describing the pregnancies that were referred for prenatal testing with molecular means, molecular testing, and they came up with this graph that shows what are the different referral reasons. And as you can see on the left-hand side, head and neck abnormalities are very common reason. They are the most common. Then we have cardiovascular as one of the high rates of referrals, musculoskeletal at kind of towards the end. CNS also is a high proportion of referrals. And on the right-hand side, the diagnoses were strictly diagnosed with whole exome sequencing, were kind of spread by different disorders, and you can see that skeletal disorders are the most common. Diagnosed with genomic sequencing, 5 out of all of those that were diagnosed with exome sequencing. Then the second highest category is Noonan syndrome, and then there's some disorders that are just one case in this set: overgrowth syndrome, skin disorder, immune deficiency, neurological disorder, and GI disorder. So this point out to the high yield in skeletal disorder diagnosis using genomic testing. And this is another study by a Chinese group that studied only cases that were reported because of skeletal anomalies found prenatal and prenatal ultrasound. And so they took 16 cases which were referred for whole exome sequencing, and very high yield of positive diagnosis. 12 out of 16 were diagnosed with specific skeletal disorder when you have a suspicion of skeletal dysplasia. And the most common were the collagen genes, which are associated with osteogenesis imperfecta, collagen A1A and collagen A1-2. Then we have 2 cases of FGFR3, which are associated with the most common little skeletal dysplasia, thanatophoric dysplasia, which is the same gene as for achondroplasia, but different mutation, which is more severe. And we have 2 cases of hypophosphatasia, which is obviously the more severe variant of this disorder that may present prenatally with abnormal fetal ultrasound. Then there was 1 case of Schwarz-Jampel syndrome, which is a recessive disorder associated with vertebral anomalies and other multiple congenital anomalies and cognitive delays. Then we have one case of short-lived thoracic dysplasia syndrome and one deletion of chromosome X, which is also associated with skeletal disorder. So this study shows very high yield of genomic diagnosis using for skeletal disorder, for suspected skeletal disorder on prenatal ultrasound. Then we go for product of conception testing with genomic testing. This study is done by Yale group with collaboration with a Chinese group. And there were 102 product of conception specimens with normal microarray that were tested with genome sequencing, and they have identified 6 pathogenic variants, 16 likely pathogenic variants. So the total proportion of pathogenic and likely pathogenic in product of conception were 22%. And then they looked a little bit further the variants of uncertain significance, which are often hindrance in this kind of studies because we don't necessarily know whether they are relevant. And they have identified 17 variants of uncertain significance that were favoring pathogenicity because they were not present in the general population, and their in silico analysis, meaning computer modeling, was showing damaging effect of those variants. So the total, if you consider the VOSs, would go up to 35% positive finding on product of conception, very significant yield using genomic testing. And the most prevalent disease categories that were identified in these POCs were those genes on the bottom, CHD7, which is associated with Church syndrome, FGFR3 again, which is associated with thanatophoric dysplasia, JAG1, Alagille syndrome, one gene for tuberous sclerosis. Interestingly, FBN1 was one of the genes identified, which is associated with Marfan syndrome, and this is the neonatal form of Marfan syndrome, which is sometimes perinatally lethal because of the significant cardiovascular manifestations, and Cornelia-de-Lange syndrome, NIPBL. And they also made a spreadsheet of different type of inheritance that was identified in products of conception that showed very high proportion of dominant condition, or 60% of all the positive findings were autosomal dominant disorders with new mutations that are not inherited. So they are happening as an accident in the formation of the embryo and are not suspected based on family history. Then 20% recessive disorders, some small proportion of autosomal dominant and autosomal recessive. Some of the genes may present in both ways. And in those genes, recessive variety of the disorder is always more severe than the dominant, and X-linked disorder, very small proportion. This same group did further analysis of products of conception and to see where the yield of positive finding is higher and where the referrals are higher. On the left top graph, their maternal age correlation with the findings on genomic testing, and the most referrals are 30 to 35, which is correspondent to the most common age range of pregnancies. Interestingly, the very early age, very young mothers, 16 to 20 years old, had very high yield of positive findings kind of like equal to the referrals, but that may be a bias because of the small number of referrals, which doesn't give us a realistic spreadsheet. And on the right-hand side, there is a proportion of referral for product of conception based on gestational age of the pregnancy loss, and the relatively smaller yield of positive finding are in the pregnancy loss late in the pregnancy over 28 weeks. The others are kind of similar proportion. The referrals are highest in the 13 to 28 weeks. And then on the bottom, they did correlation with the time of the pregnancy loss, stillbirth versus spontaneous abortion, and the proportion of pathogenic or likely pathogenic didn't differ significantly in the two cases of stillbirth versus spontaneous abortion. They were similar. So now I want to talk a little bit about postnatal genomic technologies. This is a study of pediatric patients that are affected with severe life-threatening disorders of likely genetic origin, undergoing whole genome sequencing or whole exome sequencing in emergency settings. So these are sick NICU or PICU children that are highly suspected to have genetic etiology, but are no specific genetic disorder is considered for them. So you can see here the very high yield of genomic testing compared to routine care tests, which include microarray and sometimes targeted panel tests for different spectrum of disorders. The genomic testing identifies almost 40%. The whole genome sequencing versus whole exome sequencing here, the genome sequencing is a little bit higher, not very significant, but a little bit higher than the exome sequencing. The genome sequencing, as I mentioned, is superior to exome sequencing for two reasons. One reason is that you don't need to enrich the sequence to specific part of the genome, like the exons on the whole exome sequencing, because you sequence the entire genome, and this way the coverage is even in all parts of the genome. You don't have specific genes that are with lower coverage. And also the genome also covers regulatory sequences outside of the coding sequence, intronic sequences that may be clinically relevant and are not covered with the whole exome sequencing. So having this preliminary data, the American Academy of Pediatrics came up very recently in 2024 with very high list of possible referral for whole genome sequencing for sick newborns. And they call this the neome of about 1,000 disorders that present with acute manifestations in the newborn period. And they stated that 50% of the infant deaths is attributed to genetic disorder. So they came up with very long list of possible referrals for genomic testing in sick babies with all these indications. Now this is a little bit too wide, too comprehensive for me. We usually try to do more targeted testing in the beginning when we, for instance, suspect metabolic abnormalities. We do the metabolic testing first. Some imaging also may be relevant before going to genomic testing. But the American Academy of Pediatrics was very comprehensive in their recommendations here in this article. So something that I mentioned earlier, that we are collaborating with with Raleigh Children's Institute for Genomic Medicine for such testing using whole genome sequencing. Already has a ultra rapid whole genome sequencing methodology, which uses artificial intelligence and is very, very fast. And that's what is needed for this kind of testing, because the child is sick and you have to make a decision fast. And this result set is a little outdated. It's about a year ago, so we have over 30 infants that we have tested already. But from this 19 that are in this record, there was 7 positive diagnoses, and that constitutes 36.8%, which is kind of similar, around 40% of the other data that I showed you earlier. There were 2 significant changes of care. One baby was diagnosed with alveolic capillary dysplasia, which is not compatible with life, but it's a dominant disorder, new mutation. So guided decision about the care of the child in the future, given the very poor prognosis. And the other, I'll talk a little bit more in detail later on. But for all the 7 cases that were that had positive findings, we were able to provide very comprehensive and relevant family planning information for the couples for future pregnancies. So the other case that I mentioned that was clinically very relevant clinical diagnosis with genome sequencing was is still living 2.5-month-old male presented with new-onset intractable seizures that was epilepticus. The pregnancy was complicated with partial placental detachment. At 2 months of gestation, the patient was born with normal delivery at 36+ weeks, 6 pounds 8 ounces. Postnatal course was complicated with prolonged jaundice. Then the family history was significant for 3.5-year-old sister with some delayed speech, but not seizures and no similar manifestations. The newborn screening was normal. And the metabolic screening tests that were done at the time of these seizures were normal as well. Skeletal survey showed irregular metaphysis of the long bones suggestive of rickets. Neck MRA showed luminal irregularities of the internal carotid artery bilaterally. And genome sequencing found de novo pathogenic variant in gene ATP7A, which is definitely pathogenic, de novo pathogenic variant associated with Menkes disease because it creates premature stop codon. So this helped us. Menkes disease is a disorder in which you cannot absorb copper from the food, and copper is a very important cofactor for enzymes that participate in the neuromediator synthesis. So, it's very important element, and we were able to start infusions with copper chloride initially, which were very difficult for the patient and the family because you have to do 2 infusions 4 hours each per day, and so the babies has to be inpatient for those because it's infused every day for long periods of time. Then we collaborated with a company that has developed copper histidine for subcutaneous use, which can be done just with 1 subcutaneous injection per day. And we trained the mother to do the injections, and they were able to go home. And we were following the child. He's still alive, over 2 years old. He is in a severe cognitive, has significant cognitive delay, and his quality of life is not high. And despite the treatment that keeps him alive. And related to this case, I want to show you one poster of Dr. Keller, who is a leading specialist for Menkes disease. And you don't, you cannot read all this poster, but I just wanted to show it because of the graph on the right-hand side in the middle. These are two graphs that show survival rate of children with Menkes disease that are started to treat with Cooper histidine, with this medication that this company developed. And the two graphs are showing different start times. The bottom one is starting when the symptoms occur first, which was our case, and about 3 months of age. So this treatment shows longer survival compared to the children that are not treated on the lower line of the graph. But still, most of them die early in life. The top graph shows children that are started with Cooper histidine at birth, and these sets are of children that were diagnosed at birth because of family history. Nobody suspected this condition at birth because the manifestations happen later in life at 2-3 months of age. So these children showed much higher rate of survival, and that brings up a question: can we improve the quality of life and prolong the life of those children if Menkes disease is included in the newborn screening? And I have made a case in the Department of Health of New Jersey for this condition, but it wasn't accepted because for newborn screening, you need to have easy way to diagnose all these 100,000 babies that are born in New Jersey to be tested for this. And there is no methodology other than DNA sequencing. So the Department of Health felt that it's not possible to implement this including of this disorder. One thing about newborn screening is done for different set of conditions in different states. There's set state-dependent sets of conditions that are included in the newborn screening. And in New Jersey, there are 62 disorders that are done with biochemical testing using biomarker levels to see for abnormalities that may be associated with specific disorder. And the eligibility of specific condition to be included in any newborn screening protocol is that there is treatment, there is early onset, there is easy methodology to diagnose, to screen for this condition, and to do intervention early in life. So as I mentioned, we have collaborated for the last 3 years with Ready Children Institute for Genomic Medicine, and they have pioneered in developing, in applying the technology that they have developed for rapid whole genome sequencing for use in newborn screening based on DNA sequencing, next-gen DNA sequencing. And they have spent several years in selecting out which disorders to include. They have been kind of adjusting their panel through the years based on all these parameters that are shown on the middle of the slide. Is natural history well understood? Is this a significant risk for morbidity and mortality in infants and young children? Is an intervention available that is effective and accepted? Does early treatment improve outcomes? Do the benefits of early intervention clearly outweigh the risks? for genes with more than one associated disorder, the treatments differ for the different manifestation spectrum. Can they be distinguished by rapid genome sequencing or another test? So these are all the criteria that they have used, which are pretty much the classically used criteria to include specific disorder in newborn screening, but a little bit modified to reflect the DNA sequencing methodology. So there are many questions here that are still debatable. What is an intervention? Is it FDA approved treatment? Is it clinical trial? Is it first phase of the clinical trial, second phase of the clinical trial? Is it already clinically used in the clinical trial for humans? And is it showing already benefits? When is the age of onset? I mean, that is also something that is debatable. Do we screen for all the disorders that are showing very early during the first year? Do we screen for disorders that may show within the first 5 years? And so on. Currently, in the newborn screening of New Jersey, there are disorders that are later onset. They may manifest later in life, like X-linked adrenoleukodystrophy, for instance, that may present with cerebral forms at 3-4 years of age. There are lysosomal storage disorders, Gaucher disease, Fabry disease. Fabry disease starts manifesting in teenage boys because it's X-linked disorder, very late. So these questions are debatable not only for the next-gen sequencing, but for the currently routine newborn screening. There is no answer that is accepted by all experts in the field. There are different opinions about it. So Rady Institute for Genomic Medicine did some studies using their panel of 388 disorders that they came up with after a lot of selection. And the first thing that they did was they simulated the yield of newborn screening using their methodology for 388 disorder, and they matched them with the one very large UK database of about 500,000 tested subjects, with about 30,000 of them testing for pathogenic or likely pathogenic variant in this for this 388 disorder, and they concluded that their specificity is very, very high, almost 100%, in diagnosing those disorders that were picked up on the genomic screening, genomic sequencing of this large number of database in UK. Then they did actual, not simulated, but actual sequencing of sick newborns using this, comparing their newborn screening panel to the genomic sequencing, ultra rapid genome sequencing that was done for sick children. And they resequenced those children, and they looked only at this 388 disorder. So for comparison, the genome looks for anything in any of the genes, over 20,000 genes. We have about 4,000 genes associated with specific genetic etiologies. And so there are a lot more disorders that are diagnosed with the genomic testing versus the newborn screening panel, which includes 388 disorders. And they still identified 87% of the disorders that are picked up with genomic sequencing. So vast majority of the positive diagnoses were identified with the newborn screening panel. And of those disorders that were diagnosed with their panel, 15 findings were not reported in the newborn screening, the local newborn screening, which is California newborn screening. The company is located in the hospital is located in San Diego. So this is the California newborn screening. So compared to the routine newborn screening, they identified 15 additional positive patients for specific disorders that were not picked up on the newborn screening in California because they're not included in the panel. So of those positive 15 children that were diagnosed in addition to the ones that were diagnosed with the routine newborn screening, in 43 of the 100, sorry, from all the cases that were diagnosed, not only the 15 children that were diagnosed in relation to the newborn screening, but 43 of the 104 children that were diagnosed with this panel, if the interventions were started on day of life 5, the consensus is that symptoms could be completely avoided. And so that shows the power of conducting this kind of newborn screening based on DNA sequencing methodology in early detection of children with genetic disorders, much higher number of disorders. The disorders that can be included in this kind of panels are unlimited. You can include any known disorder because the company is doing genomic sequencing, so they include all the potential genes that may be mutant associated with clinical phenotype. The question is, how do you select which disorders to include? So they are, as I mentioned earlier, unresolved questions regarding newborn screening based on DNA sequencing. Which disorders to include in the test panel? There are disorders with what we call in genetics reduced penetrance, which means that they don't present in everybody, even with the same mutation. Some individuals will have manifestations, some will not. And very typical example for this is long QT syndrome, Brugada syndrome, this cardiac arrhythmia type of syndromes, which do not present in everybody if you have a mutation. Which variants to report? Do we report variant of uncertain significance? Do we report only pathogenic and likely pathogenic variants? At this point, the thinking in Radi's team is not to report variants of uncertain significance, only to report pathogenic and likely pathogenic variants. Do we report carrier status? There are a lot of disorders that are recessive, and the babies may test as to be a carrier for a recessive disorder. Do we report that? They have decided not to report this carrier status, and there's many different reasons for that. First of all, newborn screening by definition is not reporting carriers, and sometimes we identified carriers when we do follow-up testing of positive children from the newborn screening, but that is follow-up test. That is not the actual newborn screening test. If you report carriers status for all the children that are carriers, it will be currently it is expected that with this about 400 disorders that are currently included in their panel, we will have about 2% positive rate, which is much higher than the current routine newborn screening, which is about 0.3%. So about 6 times higher. And if we start reporting carriers, it will be another 20% probably. I don't know exactly the number, but it will be a very high number, and it's very difficult to provide counseling for all these patients if we report carriers with this protocol. How to obtain consent. Now, currently, the DNA sequencing-based newborn screening is done with consent. the routine newborn screening does not require consent, and that makes the process much faster and much easier, because consenting needs for the parents to review the consent, to decide whether they want to participate in this study, to sign the consent. So that is very difficult to do for 100,000 babies born in New Jersey, for instance. So that's another question that is debatable. And the idea for this is to do electronic format that may be easier for every mother and family to review and sign online. How to organize the care of the babies with positive testing. This approach is going to result in 6 times more positive tests, true positive tests for babies with specific like Menkes disease that is not currently included in the routine screening, but it will be picked up on this test. So how do you organize the care of all these babies? It has to be a network built for this. And finally, I want to mention that we are starting a pilot in collaboration with Ready Children to do a number of babies. For now, we have committed to 1,000 babies a year, but they committed to 350 because they're sponsoring us for the babies, and we will see how it goes, how rapidly we can recruit different mothers and different babies. So I would start bringing up this for collaboration with OBGYN, maternal fetal medicine, because we need to hopefully distribute brochures to the mothers before they give birth, and so that they are aware of this available testing that will be done when the babies are born in the nursery. So that is pretty much all I needed to, I wanted to discuss today, and I'm open for questions.
Thank you, Dr. Velinov. Thank you for that extensive review. Are there any questions? I see that Dr. Rosen has his hand up.
Dr. Velinov, thank you so much for the talk. And this is cutting edge, and it's like the future is now sort of thing, right? So thank you for updating us all about this work. Hey, there's going to be a bunch of new information coming in. I just want to make a comment more than a question. I think you know, Dr. Velinov, that we are engaged in a study of whole genome sequencing on for patients who've lost babies after 14 weeks. This will be a much bigger study than has ever been published. There'll be 2,400 subjects. That'll make like 700 or 800 trios that'll be collected over about a 5-year period, and they'll be sequencing any loss over 14 weeks. I think it's an important study for everyone on our team to know about because it's available here at Robert Wood Johnson. Patients have free access to whole genome sequencing, which is a technique that costs thousands of dollars, even with the reduced cost for the test. So I think many of our team know. I know the private group is aware of this, and when patients have an unfortunate loss after 14 weeks, we may be able to give them answers. And then a second study, I don't think it's been published yet. It's initiated by the same group. These are Dr. Ron Wapner's study from Columbia University. We are contributing subjects to this study. They may have closed enrollment, but this is prenatal genetic sequencing by genomic sequencing. I don't know the numbers, but I think they're large. And we may get even more information about the right test. Dr. Velinov, you said something about you don't think necessarily that whole genome sequencing is the right test to do as an initial panel, that we should target it towards those babies' anomalies. But it seems like we don't have to be as good as we used to be. I'd like your opinion about this, that we can now, first of all, we can use ChatGPT to make a diagnosis better than us in some cases, right? We can use AI of some kind, and these tools are starting to come out. And maybe a combination of AI and whole genome sequencing will lessen the importance of physicians in making an accurate diagnosis. Do you have an opinion about that comment, sir?
Sure, absolutely. Thank you for this. I think there is a little difference between prenatal and postnatal testing. You know, I when I mentioned the whole genome, I meant, you know, the American Academy of Pediatrics recommend this postnatally because you are kind of you can do more biochemical testing on a baby that is already born. You know, blood tests and that are not possible prenatally. So for prenatal, I agree that the genomic testing is becoming first-year testing because it's difficult to do any other testing on prenatal basis. And you know, you mentioned the whole genome sequencing that you collaborate with Columbia. We communicate with maternal fetal medicine all the time about those results, and we try to provide our division try to provide some guidance about counseling of those families when we have some findings. This I wasn't aware of the product of conception study that you mentioned initially, and that's a very great thing. That's really amazing. The large number that is included. I saw you on one of my slides, something like 100 and something specimen of POC, and that is much larger than that. So I think that's great study that will give us a lot of information. But generally speaking, whole genome sequencing, even postnatally, is becoming gradually first-year testing because it can replace microarray. Definitely, it's picking up all the possible microdeletions, microduplications. The labs that are doing whole genome sequencing are able to do repeat sequencing, meaning the testing for Fragile X, for instance, or other repeat disorders. They're still not fully covering methylation disorders, for instance. Some of them are, and for that, it will help us the development of long read sequencing, which will make it possible to basically eventually replace everything with whole genome sequencing, I would think.
Thank you. I see that Elena has her hand up.
Good morning, everyone. Thank you, Dr. Velinov, for such a great and thorough talk. I just wanted to add what we're currently doing in our practice. When we have fetuses with anomalies, we are routinely today offering whole genome sequencing to all patients. And what we're struggling with a little bit, because we're trying to get these diagnoses secured as quickly as possible. And normally what happens, you do a CBS, you do an amniocentesis, you kind of start this testing process. Routinely, it's always been chromosome analysis, which takes 7 to 10 days, concurrent microarray testing, which is about 2 weeks. And if that's normal, then you start culturing cells, which takes 2 weeks, and then you get whole genome sequencing, which takes 2 weeks. So that could be 6 to 8 weeks before a diagnosis is actually made, which is a really long time. So what we're struggling and currently transitioning to is we are using whole genome sequencing almost as a first tier test. So we're taking that amnio or CBS specimen, sending it directly to that laboratory, and we are slowly transitioning to getting results back for a couple within 2 to 3 weeks, which is hugely important as people are making decisions about those pregnancies. So we haven't stopped doing microarray analysis. We do still, have that done in addition to the whole genome sequencing, because I'm not sure if there's true confidence yet that you can pick up all of those microdeletions and microduplications, but it's really changed the way we approach fetuses and make diagnoses. So, and so the last consideration, of course, is access. So today, thankfully, we can get access to patients through different either trials or agreements that we have with laboratories. So, for those on the call today, I wanted you to know that for the time being, most of our patients can get access to this without incurring a huge cost to them. So we're in a good place in terms of access, but I'm not sure how long that's going to last, as insurance companies today are not routinely covering this.
Yeah, so one comment I want to make that this genomic testing that Elena you mentioned is done on research basis, if I'm correct. So that is making it more easy to do because you don't need the lab doesn't charge for it, and if you shift it to clinical settings, that are not research, it's much more difficult. And we're trying to collaborate with some labs recently, like Baylor lab and Radi also, that may start being able to build insurances for this kind of testing, because that's the future. That's where we are going.
We're doing it actually clinically. A lot of the research, have closed. They've completed their patient recruitment. So we are doing it clinically, which is another reason we're getting such quick turnaround times. And I think the future's kind of here as well for patients who don't have fetus with an anomaly, parents who are information seekers, or parents who have a previous child without a diagnosis, or a child with a previous child with a diagnosis that happened de novo, and they're coming to us saying, well, something really significant happened before, it happened by chance. How do we know it's not something else is not going to happen by chance? We want whole genome sequencing prenatally without a clinical indication. So we're seeing a bit of that as well. And these are patients we're coordinating fetal whole genome sequencing. We're just fortunate right now that because of our previous research collaboration with Columbia is doing this on a clinical basis. They're just not charging our patients. And then there's a couple of labs that we can work with that are giving us access to somewhat affordable. But my big concern today, as we transition to all clinical and labs are going to try to charge insurance companies, and this is going to become a big access issue because of cost. So we always find solutions, creative solutions, but we're going to run out of solutions soon. And so this is what I see as our next barrier.
Dr. Velinov, we're out of time, but thank you so much for this talk this morning.
Thank you for inviting me.
All right, so with that, we're going to have to end. I hope everyone has a safe and successful day. Thank you.